What do you guys think?
I see like a isodense mass.
Yeah. So what do you think it is?
It doesn't look like a typical colon cancer.
No, it doesn't.
It could be a GIST, or some kind of large adenoma, like adenomatous polyp.
Yeah, so this was resected and it came back as plasmacytoma.
Ooh.
Yeah.
Oh, wait, can you show the bones again?
Yes.
Is there any clue?
No, I don't think so. But let me show you the bones.
So it looks like just a complete extra osseous one. Was it in the bowel?
Was it? Yeah. Let me go back to axials. Oh, this was resected. Sorry. Let me see.
Yeah, it was luminal. It's considered a primary plasmacytoma.
Cool.
So let me pause my share and tell you about the plasmacytoma. Super rare, and this is actually like reportable, or what do you call it? Case. There's only been like 30, I think 36 case studies that have. But I'm trying to open my thing. Probably should have done this beforehand. Let's see if I can. It's just a slide. I can just tell you what the slide says. So plasmacytomas are usually secondary to multiple myeloma, and like development of plasmacytomas can precede, accompany, or follow the onset of disease. And it's like Aarti was pointing to, it's usually like bone manifestation, like lytic lesions. And so isolated extramedullary plasmacytomas are rare and only occurs in up to like 10% of patients. And in these cases, the most common sites are like the upper digestive tracts. So solitary colonic plasmacytoma, which is what this was, I think there's only like up to like 30 or 40 cases that's reported in literature. And patients who do have colonic plasmacytomas, they have pretty good prognosis and they live for a long time. And up to like half of the patients are free of systemic disease after 5 years. So this was a case of a solitary colonic plasmacytoma, which is like uber rare.
Very cool. So they resected it, and they don't have to be on any chemo?
They in this case, they resected it because the patient developed colonic obstruction.
This is a young patient, and they had they presented with jaundice. You can see that their bile ducts are dilated, and the CBD is dilated. And we come down into the pancreas, and there is an expansile lesion here in the pancreatic head. And we also see that they have multiple renal masses. So any thoughts?
Lymphoma.
Good. Anything else?
Gitanjali put VHL.
Okay, good. And so those were the things we were thinking about, and we also contemplated IgG4. In IgG4, you can get both pancreatic, focal autoimmune pancreatitis, or IgG4 related pancreatitis, as well as renal masses. I've never seen them actually be this large in IgG4, but since it was both renal and pancreas, we thought about that. We also thought about VHL, like, are these multiple RCCs? Although in VHL, the RCCs are usually more indolent. And so we thought that would have been weird to go to the pancreas. And it doesn't really look like a clear cell. They're more like hypoenhancing masses. So yeah, Cookie, you got it. This was, and then they biopsied this renal mass, and this came back as a B-cell lymphoma. So
how old was the patient?
19.
Wow. Yeah, well, I think that would also clinch it. 19-year-old. Is it large cell or Burkitt's?
It's large cell, diffuse large B-cell lymphoma. And the other interesting thing that we were kind of wondering about is that there wasn't a lymphadenopathy anywhere else. So that was just kind of interesting. And I guess that's just one of the take home points is you don't have to have lymphadenopathy. It can just be, organ, affects these like solid organs.
The spleen is a little bit big for a 19-year-old, no?
Yes. That's a good thought. Yeah.
That's a beautiful case.
Yeah. Yep, it is big.
Good question.
Mhm.
Usually the lymphoma in the pancreas is not associated with duct dilation.
Yeah. This didn't look like, it didn't look like an adeno. It looks expansile and the duct wasn't super dilated, but yeah, it is dilated. And I assume it's just that when lymphoma gets big enough or any, it can obstruct the duct as well.
Yeah, I mean, it's the ampulla. So you're obstructing the ampulla. So you're going to have obstruction or not.
Yeah, and it was obstructing the CBD as well. But if those had not been obstructed and we had this big mass, that would have been even more of a clue for lymphoma. Okay. This is my next case. This patient has a history of biliary cirrhosis. And this is a lesion that they had in their liver. You can see this is the pre-contrast. There's some T1 hyperintensity in it, so maybe some hemorrhage. This was the arterial phase. So not too much enhancement, maybe like a little globule of enhancement here and a lot of peripheral enhancement. And then this was the delayed. And they do have a history of biliary cirrhosis. So at this point, what do you guys think? I'll show you the T2. This is the T2.
Can you show the delayed one more?
What'd you say?
The delayed, can you show the delayed? Sorry, one more.
Yep.
Or like an unusual cholangio, maybe?
Yeah, so we were wondering if this was like a necrotic mass. It did look like there was some maybe delayed nodular enhancement here that was progressive. So anyway, this went for biopsy and it came back as necrosis and hepatocytes and no malignancy. And then actually went for a second biopsy, an MRI guided biopsy, which we do here when we can't get a diagnosis. And it came back again as necrosis. And so anyway, we basically had this liver biopsy, we had an MRI guided biopsy, we had another liver biopsy, but okay, so this is now 9 months later. Here is, oh, sorry. Okay, now 9 months later, the mass looks like this. In the process, basically with all those negative biopsies, we started contemplating with whether this could be an inflammatory pseudotumor. And you can see that there's like a central scar. There's this kind of lobulated looking mass. It now looks different. Like it looks almost like solid arterial enhancement, washout. So anyway, this ended up getting biopsied again. We said that this is, especially given background liver disease, this basically looks like HCC. They re-biopsied it again and it came back well-differentiated HCC. So I guess my question for the group is like, what do you think was going on back here? Like, and have you guys seen this, like something going from necrotic to like a solid, well-differentiated HCC, or maybe do you think like it was just that little solid part, or what do you guys think?
That's very weird. Do we have any molecular on that? Like, is it beta cat? I mean, do we have anything on that, or it's weird?
Yeah, no, let me see. I'm looking at the path report. Just says well-differentiated HCC, positive for AE1, E3, arginase, glutamine synthase, negative, blah, blah, blah. I don't know if any of this is helpful, but it doesn't say anything about.
On the path, when it's discussed, can they figure out why it was negative ×3 before it became positive?
No. I mean, and they even aspirated and like for a while, we kind of was like, maybe it's a weird abscess, maybe it's an inflammatory pseudotumor. It just kept coming back necrosis. And usually MRI guided biopsy, we're pretty successful. They'll do FNAs with the pathologist present, and they just were basically getting necrotic tissue, which is kind of what it looks like here, you know? So just a bizarre case. Okay, my next case is this one. We see a lobulated mass here going through the sciatic notch. And here it is on T2. And here it is post-contrast. So this is the venous phase. This is the delayed phase. And this mass was not present about a year ago. Any thoughts?
And demographics of the patient?
An older male.
I mean, does he have a sarcoma history, or is this a mucinous? You know, it's not mucinous. Does he have a sarcoma history, or?
Yes, and actually, you see there's like a scar tissue here? So I didn't want to give away what the history was, but I just thought this was interesting. So this ended up being a myxoid liposarcoma. And I showed one at this conference a couple of months ago. If you go on the website, you can watch that one as well. But it was very similar in that because it's myxoid, it's really T2 bright. If I had just seen this, because it's going through the sciatic notch, it's bright and it's enhancing, I would have thought about like maybe a huge nerve sheath tumor. But because it popped up in the past year, this was a recurrent myxoid liposarcoma. So it's going to be a lot more aggressive than just a nerve sheath tumor would be. And then, as I discussed a couple of months ago when I presented the other case, the other one was actually in the retroperitoneum, in the mesentery. And usually when we see myxoid liposarcomas, it is a met from an extremity sarcoma. In this case, since it's gluteal, I guess that is where the extremity, or part of the extremity that it came from. But anyway, so this was a myxoid liposarcoma. And then I have one more case, and it's on the other computer. So let me just stop sharing this for a sec. Here, you can see that there is a retroperitoneal process going on here. So Gitanjali's guessing Castleman. So Gitanjali, why are you saying Castleman's? Oh, she has no mic. Okay. Any other thoughts? Any other guesses? So Gitanjali's saying enhancing lymph nodes. Good. Awesome. So this actually was Castleman's disease, biopsy proven. And so one of the clues is that we've got multiple lymph nodes. They actually, instead of, you could think like, oh, this is a fatty mass with solid components. Could this be a liposarcoma? But you can see that these guys look actually like large, very large lymph nodes with kind of a morphology of a lymph node, but they're giant. So that's one of the clues about Castleman's disease. So Omar just taught me more about Castleman's this morning, but the main points are that you can have either unicentric or multicentric Castleman's, and the most common sites are in the chest or in the abdomen, with unicentric being slightly more common in the chest and multicentric slightly more common in the abdomen. The multicentric variety, the unicentric one where you just have one sometimes avidly enhancing node can often be treated with just surgery. The multicentric kind is a benign lymphoproliferation. So it's on the spectrum towards lymphoma, but it's considered benign, although they will treat it sometimes with chemotherapy. And then it can also progress towards lymphoma. So, and then another thing that Omar taught me this morning was that this fatty proliferation around it is something that can be seen with multicentric Castleman's, because it's a lymphadenitis that causes inflammation and then fibrofatty proliferation, just like in inflammatory bowel disease. So if you see all that kind of dirty fat around it and fatty proliferation, don't get tricked into thinking it's a liposarcoma. This could just be Castleman's disease. And this multicentric form is more common in patients with HIV, although this patient does not have HIV.
I also read that there is association with sometimes brown fat proliferation. So the infiltration of the fat has also been thought that it could be brown fat. I don't know if that holds true, but that's what I read way before.
Cool. I had a similar case to this, and it had a lot of fatty proliferation and like one giant thing. And we're thinking, we don't have the definitive diagnosis yet because it's even multiple biopsies have not been able to like clinch it, but we're thinking that's also Castleman's. And the fat proliferation though did trick us initially. We were like, oh, is this a, liposarcoma? So great job, Gitanjali. Thank you, Omar, for the case. And I'll stop sharing. Okay. Teresa?
Yes. Let me share my screen. Okay, so this is kind of a quick one. Just wondering if anyone else has seen this before. So this is a transplant. It was originally performed on the 18th. And then 6 days later, they did a routine follow-up. And now you can see the difference in the arterial waveforms. So on the most recent one, we see this double peak appearance. We had looked this up and we found something that this is suspicious for. Has anyone seen this, or do you know what this could be? Can you guys hear me?
We can hear you. We just don't know what to do.
Okay.
But you are a little faint, if you could speak up.
Oh, is this better or is this better?
That's
Yes.
better. Yeah.
Okay, maybe I'm talking to the wrong microphone. So we recommended a CT angiogram, and here is our, let me move this up. So you can see here's our celiac. And then it comes into the main hepatic artery. Let's go to the coronals. So
Is there like a dissection with, because it looks like half of the lumen is thrombosed.
right, so half the lumen is thrombosed, and then I think you can also see a dissection flap in here. You can see it on the sagittals a little bit better too. So actually on the ultrasound, this double peak appearance, I thought is that it was related to an active dissection with getting pulsations in both lumens. There was an article that was found, but I can't even find it anymore. So actually on the ultrasound, they suspected an arterial dissection, and they got the CT, which showed it. And then, I think there was 12 hours between the ultrasound and the CT. So by the time we got the CT, half of the lumen is thrombosed. And then they took him to the OR the next morning. And by that time, the entire thing was thrombosed. They said the artery was completely thrombosed and purple. So they ended up having to, do a bypass. And but I thought that was very interesting.
It's an awesome case.
Yeah, I've never seen this double peak thing. That's really cool. So
There's
how
one article, I couldn't even find it.
How far after the transplant was this? And do you feel like we know why it might dissect?
The transplant was 6 days prior to this, and the transplant was 6 days prior to this, and this was just a routine follow-up. The original transplant was complicated. looks like they had to take him back to do the biliary anastomosis. Like they left him open and then went back into the biliary anastomosis. So nothing regarding the arterial system. And then a routine follow-up 6 days later showed this appearance.
Very cool.
That's all I got.
Okay, Roopa.
Let's see.
Hey, Aarti.
Hey. While you're pulling up your case, just a little reminder to everyone, we're not going to have conference next week because of RSNA. So maybe we'll see you online at RSNA.
Yep. Can you see my screen okay?
Yes.
Okay. So young patient came in for fibroid evaluation. So T2s, fat T2s, post-contrast. Any thoughts on what's outside the uterus?
I mean, it's probably a perineal leiomyoma, sarcoma, or some complicated
Leiomyosarcoma. So that was kind of our thought, is there are leiomyomas everywhere. So like Cookie said, like a parasitized one, and she had had C-section 3 times before, so definitely slightly higher risk also. Or the other thing we thought of was, could it be a fibroid that had traveled along the round ligament, like we see the ones along the broad ligament? Other unusual differentials we had given was other mesenchymal tumors, like in the leiomyoma spectrum. Didn't look typical for something like a desmoid, not the spiculated margins we're used to seeing, or the progressive enhancement. Very heterogeneous on T2s. Areas of low signal. It looks different from the fibroids that are inside the uterus, a lot more heterogeneity, either necrotic, non-enhancing, or cystic areas of degeneration. So those were the differentials we gave, but when this came out at PATH, it turned out to actually be a low-grade fibromyxosarcoma. So not a fibroid-related variant, so no smooth muscle component in this. Just all the low signal areas were fibrous tissue, the high signal areas were myxoid tissue. And in the ortho literature, this is well known. They call this Evans tumor, described by a person named Evan. So these are histologically benign, but they can have local recurrence. And all they are composed of fibroblasts and myxoid tissue. And one of the typical appearances they describe is what's called a gyriform pattern, wherein the fibrosis and the myxoid tissue gets folded over and over, and it looks like gyra in the brain. So when you have that pattern of enhancement, it's usually a deeper soft tissue mass. This one happened to be somewhat subcutaneous and sort of a pitfall because it was along the abdominal wall, deep to where there were plenty of other fibroids as well. So visually at first, it's a little bit of a mimic, looking like fibroid spectrum, but soft tissue sarcomas can happen in these more superficial planes also. So this was just an Evans tumor which came out, and we've been following her, and she's actually done fine. They have a low malignant potential, and the uterus, of course, was just typical fibroids. So just a quick little case.
Roopa, quick question. You said it's benign, but they still call it a sarcoma.
Benign means it's low malignant potential because it's low grade fibroblasts and low grade proliferation. The mitotic activity in these is low. So I guess it's a sarcoma, but on the lower end of the spectrum. And they do a specific stain called MUC4, which they say is very, very pathognomonic for these Evans tumors. So in the ortho world, this is a well-known entity. In the female pelvis, we haven't seen too many of these. So the ortho surgeons are very familiar with this, actually.
Very
That's
cool.
all I have. Yeah.
In the extremities, are they also like very T2 dark like this?
They look like this too, and,
Yeah.
and they have that more gyriform whorled appearance in the extremities too. And they can sometimes even have like a fascial tail-like enhancement also. Just an unusual location on this.
Cool.
This is a 36-year-old patient who has a history of multiple abdominal surgeries. So this was about a week ago. This was her CT. And it looks like she has a lot of extensive post-surgical changes of the bowel. So if you could just remember that CT. So as I'm scrolling through, does anything kind of pop out?
Can you show the coronals too for them?
Yeah.
Something in the stomach.
Right. So that is the coronal.
Does the patient like swallow something? Sorry, I actually
She did.
attend to something else. I missed your history, but
Oh, okay. No, that's exactly right. She did swallow several linear objects, which is actually why she has such an extensive history of bowel resection, because she has a very extensive psych history. So I just wanted to show you what these actually, do you have any guesses as to what these are before I show the EGD pictures?
Gitanjali is saying pencils.
Or pens,
Excellent.
I guess, if they're metal.
Yeah, no, that's exactly what they are. So let me pull up the, ignore any names you see on this, I'm sorry, but this is what she ingested last night. So they were able to remove these endoscopically without injuring anything.
Wow.
But that's what.
Very cool. And that makes sense that the lucent part around those things is the wood of the pencil.
Yeah, the lead center and the lucency.
Cool. I couldn't figure out why they were clustering together. I thought maybe
But
some
swallow them together. Craziness. So,
I thought maybe they were like magnetic or something.
Good thought.
Yeah. So that was just my interesting case of the night.
Someone else is also asking why they're so organized in parallel. I guess she swallowed them in mass, and maybe there's a rubber band around them. I don't know. It seems weird to me that they're all sticking together like that, but cool.
yeah, I don't know. There's a pseudo tumor cerebri patient. She has a peritoneal shunt, and there's some issues with this.
Okay. Thank you.
Thank you, Regino. Anyone else? And someone actually sent me a follow-up paper, but I'll have to read it first before I get back to you. Oh, I guess hold on, let me share it. If the person...
Aarti, I can share it too.
Okay, yeah. Why don't you share it?
I just found this, since we were talking about this double systolic peak. I guess if I click in this, it should open. I guess not. Hold on, let me share screen. So this double pulse bisperience, they talked about in this pediatric liver transplant article, where I know that dissection case Teresa showed was super cool, but see this, do you guys see my screen? So
Yes,
this shows a normal systolic peak, and they said for this child, it was an expected finding and transplant remained uncomplicated after 5 years of follow-up. So I wonder in pediatric population, is this a variant? And it just raised the question of when should we worry about when we see this?
And they call it pulsus bifurcans,
Bisperience, like the double, like when we hear the heart, we've heard a pulsus bisperience many times. But this was interesting because they said intrahepatic artery waveform showed a systolic double peak in 28% of patients, non-significant trend toward the double peak, which was more common in patients without than with complications. But clearly the case Teresa showed had a very nice dissection. So
And mine also, the peak systolic velocity went from about 48 to 255. Oh, can you hear me? Sorry.
the RIs, yeah, the RIs, we should put it in context of the RIs and the change in waveform rather than a single reading, maybe.
I'll find the other article and send it to you guys.
Yeah, and I don't know much, so it's just a question for the group because I just found this.
Cool. Okay, we'll have to follow up. To be continued. Okay, unless anyone else has cases, we will end. Okay, so no case conference next week, RSNA, and we'll see you in 2 weeks. Take care.
You guys.
Thanks all.